my job is, how do we integrate the components of NAFLD into the existing, NBCDCS program? This is what I'm trying to do in the next 10-15 minutes. Well, we started around 1975 when India started, responding to the NCD challenges with some vertical national programs, and we tried to pilot that in about 10 districts in 2008. And by 2010, we have the program of NBCDCS being implemented in about 100 districts of 21 states. And then NHM happened and was rolled out in 36 states in 2013-14, and we have the number still counting to about 468 in 2015-16, and then there is the paradigm shift, and we had the introduction of the comprehensive primary healthcare package through the health and welfare centers, and the population-based screening for the common NCDs had also happened in 2018, and now we are in 2021 when we are trying to integrate yet one more component of NCD into it, and that is what we call the non-alcoholic fatty liver disease, or NAFLD. So the program, if I have to, give a glimpse of that, has got certain objectives. Like one of them, obviously, is the health promotion. Second, as I said, is population-based screening. And with the population-based, we still also continue our opportunistic screening at all healthcare levels. And the prevention and control of the chronic NCDs, of course, is the main backbone of this disease. And we do a lot of capacity building in the various components of the program. And we have support for the diagnostic and other therapeutic measures at all levels of the healthcare delivery system. So to do this, we have got the NBCDCS infrastructure across the country in the form of the state or the UT NCD cell. This is the administrative cell, housed at the headquarters of the state. And similar structures are also there in about 678, districts. But the primary area of care comes in the district NCD clinics, where we have, which we have in about 643 districts, and we are still counting. And we also have, for the component of the cardiovascular diseases, we have got dedicated cardiac care units, or the CCUs, in about 190 of these of the districts in the country. And for the chemotherapy component of the cancer care, we have the district daycare centers in about 237 district hospitals. And if you go down to the CACs, we have got the NCD clinics in about 4,807. And as I said, the population-based screening, which happens at the doorstep, is joined by the referral of the continuum of care to the A&M, and then to the subcenter, and to the medical officer at the PAC, and the NCD clinics at the CAC, district hospital, and the tertiary care center. So these continuum of care we are trying to capture digitally throughout as well. And let me give you something about the population-based screening, which is a package of the comprehensive primary healthcare now. We are targeting those people about 30 years of age, but let me warn you here that when we say screening, it doesn't mean that those people who are below 30 and who wants to get themselves screened cannot drop in at the NCD clinic. They can very well drop in, but those screenings which are happening at the doorstep by the ASHA, we are targeting the 30 plus years of age as of now, and the ASHA comes with a comprehensive, we call it community-based assessment checklist, or the CPAC form, and then the ASHA screens them, and based on the score which the person has, the patient is being referred to the A&M and then higher up. So this is the first step where the healthcare worker is getting in touch with the person and taking history. So this is the first point where we are doing health promotion as well. So if you see this program from the NAFLD point of view, we are already asking the height. We are also measuring the weight, and we are now thinking of providing some component in the app which the ASHA is using for calculating the BMI as well. So For somebody whose weight is being measured, whose height is being measured, and whose BMI is being calculated here, that is the first step when he is being, sensitized for some other disease which could happen to him if he happens to, falter in these measurements, which is, that disease in our mind is NAFLD. Of course, if we take care of the height, weight, it will not just take care of the NAFLD, it will also take care of many of the diseases. But if you see from the NAFLD point of view, this is the first point which we are having with the community. Then the non-alcoholic fatty liver disease, now we all know it's a build-up of the extra fat in liver cells, and that not necessarily is caused by alcohol. Alcohol also causes certain kind of diseases for which we are also aware and we are also doing it. But it should not have this impression that if you are not drinking, if you are not, using alcohol excessively or not drinking at all, but if you don't take care of yourself, if you don't take care of the fats getting deposited in your liver because of faulty lifestyle, eating habits, and also physical inactivity, we should not, keep on thinking that NAFLD or fatty liver is not going to happen to that person. So it's we all know that it's normal for the liver to contain some fat, but even among the doctors also, if you see 15% or 20% fat, some of us may just brush it off saying that, oh, is it quite common nowadays. That's why we are having this non-alcoholic fatty liver disease in order to increase our awareness about the presence of fatty liver leading to some other complications. The burden, which we have already understood, the huge burden of NCDs, and in that huge burden of NCDs, we also know that for the prevalence of NAFLD is about 30% of the general population. So if you take care of this 30% of the population by, making certain changes in an existing program of NPCDCS, we will be taking care of that 30% of population. We already have a mechanism where, fortunately, there is an interface between the healthcare worker in the form of ASHA or NM and the potential patients of NAFLD. And it is it is high time that we all, encash on that opportunity. So 2/3 of the diabetics usually have the NAFLD-S. So if you take care of the NAFLD, you can also know that we can also, note that 2/3 of those diabetics are also going to be taken care of. So in a way, the confluence of the risk factors for the NAFLD and NCDs, I said in the beginning also, are quite common, with some emphasis on some areas for NAFLD, particularly the metabolic syndrome, hypercholesterolemia, then obesity, diabetes mellitus, and the risk factors of physical inactivity, unhealthy diet, and suffering from hypertension, family history, etc. So many of the risk factors are common. So when you take care of the risk factors, like if you become physically healthy food, it's not just for the liver, but it is also for the other NCD. So this is a win-win situation for both, and we have got enough reasons now why we were targeting the NAFLD. So the ministry has already released an operational guidelines, which was prepared in collaboration with the Ministry of Health, NHSRC, the DGHS, the NILPS, and other partners like UNDP and WHO. We have had a series of sensitization workshop trying to tell the liver is in the focus of the NCD program, and if you take care of liver, many of the NCDs in the NPCDCS program would be taken care of. So this is the launch of the NAFLD operational guidelines. And fortunately, we are happy to announce that India is, in fact, the first country in the world to identify the need for action for NAFLD in the form of a national program. So the NCD program has got another feather in it, that NAFLD is being incorporated into the existing program. So how we are trying to do this? I had already explained the infrastructure. So the health promotion, awareness, generates screening, early activity, and timely, affordable, accurate diagnosis, and then providing affordable treatment and rehabilitation wherever required. This is usually the stages, not just for NAFLD, but for any of the lifestyle-related diseases. But let us try to customize it for NAFLD. Now, the promotion and prevention activities for NAFLD. I had already told you that the ASHA visiting and asking you those questions for measuring your parameters is also a health promotion strategy already. So over and above that, we will be now integrating the healthy liver messages in our mass media or social media campaigns of the ministry, and we are also going to celebrate many health days with the liver in focus. Coming up now on 19th of April is the World Liver Day, and we are around that time we will be having a lot of sensitization workshops across the country so that we sensitize ourselves, not just the patients or the population, but the medical, the health functionaries on issues of NAFLD. Now, the current activities under NBCDCS, as I already told you, the ASA is already doing this, and in the proposed activities for NAFLD, we will be seeing observing for abdominal obesity. This will come from the waist circumference, which he is already measuring, and family history of diabetes, hypertension, coronary heart disease, liver disease, gallstones, and cancers. And the ASHA is already measuring, edema for other conditions like, antenatal mothers and so on. So we can increase that screening population towards that. So the proposed activities is already there. It is not overburdening the ASHA to some more extent again, but it is trying to get out, take out the data which is already there, tweak them in such a way that we get whatever is required for NAFLD. At the PAC level, when the medical officers diagnose the common NCDs through the population-based screening system, or the patient, examines them on NAFLD in focus and refers them to CAC for diagnosis, etc., is also some of the activities for which we are proposing at the PAC level. So the referral at the PAC, the diagnosis and the referral is at the PAC level, and this is already recorded in the Form 2, and we will try to put in the liver component there. Then when the patient reaches the CAC, in the already existing activities of NPCDCS, now we will put in some more component, like the doctor in the NCD clinic in the CAC will now be enabled to perform an LFT and the CBC, the labs, the public health laboratory system. Many states, they have got different schemes of laboratory investigations based on, say, for example, Bihar has a scheme under Chief Ministers of Bihar. So in there, if you increase the number of the different labs, if we tweak it in such a way that you have got LFT and CBC for sure, then you have got what is known as the FIT4, the fibrosis, for score, etc., which is required for stratification of advanced liver disease. Then from the FIT4 or the NFS score for on application, if you build the capacity of these doctors, they can get it investigated and they can even diagnose it as well. Then when they know that this person is falling into one category or one stage of the NAFLD, then they can refer to tertiary care in the district hospital or in the medical officer. So these capacity building of the different health functionaries can happen after in the CAC, and it is not a big deal, and we are not adding anything which is very, very resource intensive. It is doable. And when the patient reaches the district hospital level, over and above the normal activities of the district hospital activities for NCDs, we are trying to put in some detailed investigation through the district hospital laboratory and management of patient through the screening. Say, for example, there should be a management of NAFLD referral, then the risk stratification of advanced liver fibrosis. So if there was no facility in the CAC, it will be done here. And for patients who are in the intermediate risk for liver fibrosis, we may do what is known as fibroscan according to the availability. So many of the district hospitals in many of the states can propose in their PIP that we would like to procure fibroscan, and they can get this done here. Accordingly, the capacity building can also be done here. Then recording continues with the inclusion of liver report in the Form 4, 5A, 5B of the NPCDCS program, which is already there. So then here this is where till now, till the district hospital, it is in the realm of in the domain of the National Health Mission. But the patients do not stop there. Patients will not stop there. The care will not stop there. So the next level of care is usually the medical colleges, your central government institutes, where the more definitive care of NAFLD will now happen. So we need further risk stratification of the advanced liver fibrosis. If there were no facility in the district hospital from where they have been referred, and for patients with intermediate risk, we can now perform the fibroscan. So what we mean to say is, if there is a medical officer in that particular district, we need not build the capacity of the district hospital, rather build the capacity of the medical college with fibroscan, etc., and do it. So the choice is with the state government, which facility they should, and they will be easily able to develop for the care of for the diagnosis and management of NAFLD. It's usually done in the gastroenterology department if it is available. If not, the medicine department can also do that. So to handhold the NAFLD integration, we can also hope in the future for a national center of excellence, which can, design training manual, capacity building of master trainers, and also design IEC material. Then monitor and evaluate the whole implementation of NAFLD component in the NPCDCS, because we know that whatever gets monitored, it gets done. So we'll have to do a lot of monitoring. And the National Center of Excellence may be assisted by the regional, say, 3-4 states together. If we have a good, good institute, say in Bihar, then that center can take care of 4 or 5 states. And then even the states can also have their own state center of excellence for implementation of the NAFLD into the NPCDCS, and say for adapting, translating to the local language, and the dissemination plan of the IEC for NAFLD. So these are some of the proposed center of excellence activities, and we already have the National Multi-Sectoral Action Plan, knowing very well that health, especially the NCD, is beyond health sector, and we need to work with many various stakeholders, and that is why we already have what is known as the National Multi-Sectoral Action Plan, and NAFLD needs to sync with the vision and the goal of and this is what we are already doing it, and some of the key strategic areas and the key outcomes of the National Multi-Sectoral Action Plan are already listed here. Here we need to see it as we have been doing for the last 5-10 minutes, trying to see it with the lens of NAFLD, so that we figure out whether things are already there for NAFLD and identify them, recognize them, and assure ourselves that we don't need anything. But wherever required, where we think that there is something specific to be added for NAFLD, we try to add there. And we also have generic promotive strategies like the Fit India, launched by the Honorable Prime Minister in September 2020 for the age-specific fitness protocols, in which Ministry of Health is also partner in developing, and other strategies like the Eat Right campaign, for taking care of the unhealthy diets. And the way forward, which we see now, is what we are doing now, sensitization workshop. Inclusion, we have already done it, and we are trying to do it in the PIP guidelines, and then trying to include the financial the guidelines of the PIP, then monitoring through the implementation through PIP, and then ensuring whatever is required in terms of diagnostics and therapeutics for NAFLD, then building the capacity and monitoring through, say, for example, the formats of the BBS or the continuum of care HMIs that the ministry is gradually developing. And we may start in some pilot, but I think we are already doing it. We are already scaling up all across the country. We have given the operational guidelines to every state of the country and UT, so they can already start, asking the ministry what is required for NAFLD inclusion in NBCDCS. So this is in brief what I wanted to share with you in a short span, how we have traveled from 1975 onwards to 2021, trying to rope in different components of NBCDCS like the kidneys or the COPD or stroke, and now the attention of due attention being given to non-alcoholic fatty liver, not just the liver component but the non-alcoholic fatty liver, knowing very well that if you take care of the non-alcoholic fatty liver, many things about the LCT would be taken care of. So this is what I wanted to share. Thank you for giving me this opportunity.